It's really, really great to have you. For those of you who maybe don't live in Washington or understand the sort of the Washington political and economic ecosystem, PhRMA is an incredibly important organization in this town. Probably the most blue chip and the most respected trade association, just with a lot of history and a lot of influence. So it's really our honor to have you here. So, Trump's first 100 days. I think, what are we, day 95 or something? We've been talking a lot across the last 2 days about the first 100 days. Tell us how you at PhRMA have approached engaging the White House in these first 100 days.
Well, it's just a quiet time in the pharmaceutical industry. But let me just start by saying thank you for having us. We enjoy the partnership. Congratulations on the growth of Semafor in this conference, and delighted to be here. The first thing I would say is there's been a lot of engagement with the administration, and that's frankly a refreshing change. If you think about the last administration, candidly, there just weren't that many receptor sites for business generally. So we've been heartened by the fact that we've been able to have meaningful conversations with policymakers across the constellation of issues that we're engaged with. I think our approach to the administration in this environment is really two-pronged. One is staying, very focused on our core priorities. If there's anything we learned from the last go-around, is that you can really get distracted from the day-to-day noise. And we are very focused on those core priorities, which I know we'll talk about. And then secondarily, we're looking for areas of common ground. And the good news is I think there's a lot more common ground than areas of disagreement. And I just maybe point out a few at the outset. I mean, obviously, there's broad-based support for ensuring that we continue our leadership role in developing new treatments and cures. We don't lead the world, by the way, by accident. We lead the world because we have this really special ecosystem in the US. We have a very strong intellectual property protection in the United States. We have a transparent, efficient regulator in the FDA that really sets the bar around the world. At least up until the passage of the IRA, we had a market-driven reimbursement model that recognizes new innovation. And we have this very unique facet of our system in the US where private industry can collaborate with academia and the government, and everybody sort of shares in the fruits of those interactions. I was recently in Japan meeting with the Prime Minister. They just sent a delegation to Cambridge, Massachusetts, to really study our secret sauce, the access to capital, the ability to collaborate, some of the other pillars of our ecosystem. So number one, everybody wants us to continue to lead the world. Number two, this administration is really focused on encouraging more investment in manufacturing in the US. You've probably seen some of our members have announced just in the last few weeks over $100 billion in new investments, Lilly, J&J, Genentech. Over 70% of the medicines that are consumed by Americans, measured by value, are manufactured in the US and driven by a lot of the tax changes in the first Trump administration, which are going to be built upon, we think, this year. I think you'll see more and more US investment going forward. And then finally, the administration just put out an executive order on drug pricing. One of the areas that they focused on that we completely agree with is the growing role of middlemen in our system. Over 50% of what's spent on brand medicine actually goes to somebody who doesn't make the medicine, which makes little sense to us. And these middlemen are really, I think, profiteering, frankly, off the system at the expense of patients. So those are three of the areas where I think there are common ground. We're obviously not going to agree with the administration on everything. We have agreements and disagreements with every administration. We don't agree, for example, that tariffs should be imposed on medicines. We'll talk about that. As you think about the MAHA movement, there's a lot to agree with there in terms of focus on better food, lifestyle changes, addressing environmental toxins, et cetera. But we disagree with some in the movement who would question the safety and effectiveness of FDA-approved medicine. So that's just a general sense.
Just a short
list of things going on in our space.
And you said to me in the green room that there's maybe the busiest time in your tenure.
Yeah, I've been doing this for 10 years. It's clearly been the most intense.
So one core issue that your industry is facing is looking to fix is what you call the pill penalty, which is included in the Inflation Reduction Act. I know last week the White House issued an executive order to ask the HHS to work with Congress on this issue. Could you explain to everyone this issue, the pill penalty issue?
Yeah, just for the uninitiated or people who are not following our
It
space
sounds painful.
day to day,
It's
there are two kinds of drugs. There are pills, which we commonly know of as medicine and take, and then there are biologic medicines that are typically injected in a physician's office. And under the Inflation Reduction Act, which passed a few years ago, there's two different timelines under the law for when the government will set the price of a medicine. So you have to be on the market for 9 years for a small molecule or pill before the government sets the price, and 13 years for a biologic. There's really no basis in science, for that difference to exist. It's really an arbitrary difference. So we're seeking to align the 9 years to the 13 years. So what's the problem? I think the problem is twofold. One, on the science, there's no scientific basis for the difference. If you think about mental health medicines, for example, only small molecules can traverse the blood-brain barrier. For cancer, there are certain proteins that can only be gone after with a small molecule. As a practical matter, what patient wouldn't rather take a pill than travel to a physician's office to have an injected medicine? And then you think about cost. Not only are small molecules more affordable, really the law is setting up an incentive to develop what are typically more expensive medicines and biologics. But there's really nothing, the unique attribute of our system and why we have this societal bargain that we do is that we have patent protection for a period of time and then a drug goes generic. We're actually the only thing in the healthcare system where the price goes down over time. And there's nothing cheaper in our system than a small molecule medicine, which is the easiest type of medicine to genericize. It's typically much harder to do that for a biologic. So for both scientific and cost reasons, we think it doesn't make a lot of sense. We were heartened that it was included in the EO, as you mentioned, and there's growing, I think, bipartisan support to address, which is what is really an unintended consequence of the law. And we're already seeing sort of an outflow of capital to investment in small molecules, which is unfortunate.
So as you can imagine, we've had more conversations about tariffs on this stage in the last 2.5 days.
I've noticed that.
A pretty common sort of theme has just been the disruption that it's caused a lot of business leaders, and frankly, the pause that many business leaders are sort of facing with the uncertainty and the unknown. How are you in your industry looking at the tariff question?
Well, we're heartened by the fact that medicines are currently excluded from tariffs, and that's historically been the case. And the reason historically medicines have been excluded are because of some unique attributes of our industry. You have generic medicines and innovative medicines. 90% of prescriptions are generic. They tend to be low cost, after they become generic, and they're low margin for those producers of generic medicines. So if you do have tariffs that are imposed on medicines, it can lead to shortages and disruptions in care for very commonly used medicines during various surgical procedures and so forth. It can also lead to higher prices, which can be a challenge for consumers. So for those reasons, and the fact that, it's hard actually for us to pass price through because of unique aspects of our industry. There's actually a inflation penalty if prices rise by more than inflation. So it's not an easy matter of passing through price as it might be for other sectors. So for those reasons, typically medicines have been excluded. Look, I think the administration is trying to solve two problems. One is to repatriate manufacturing. And as I've already said, the best way to do that is to continue to build on the tax reforms that have taken place and frankly, to streamline regulation. It takes 5 to 7 years to build a new manufacturing facility, state-of-the-art biopharmaceutical facility in the US. So there's a whole, long list of 3-letter agencies that get involved in that, whether it's OSHA, EPA, FDA, et cetera. You have state permitting. So build on the tax reforms, streamline regulation. We'll have continued U.S. investment on the part of our industry. The other problem they're trying to solve, which needs more attention, I think it's a bigger problem, is that there are a set of essential medicines where we have more reliance on China, and that raises serious national security concerns. And as an industry, we've said that we're willing to sit down, roll up our sleeves, and really try to solve those issues. In our view, we should focus less on, do we have certain API, active pharmaceutical ingredient, coming from friendly countries, and more focus on this reliance for a subset of medicines that are really important, where we do have reliance on one country.
So very quickly, because we're close to the end of our session here, thoughts on the MAHA movement?
Yeah.
How do you view it? And then the second question is to go back to China. There's been a lot of discussion about China, innovation, maintaining America's edge. Love to hear your thoughts on that too before we close.
Yeah, and maybe
Do the second first. Okay.
maybe do the second first, and just sort of interject on this point I made at the outset about the growing role of middlemen in the system. First on MAHA, again, I think there's a lot of areas of agreement around lifestyle changes, environmental toxins, making sure that we're getting at the root cause of chronic disease. The right to focus there. 1 in 6 Americans has a chronic disease. It drives 80% of healthcare spending. We can't grow the economy if we're burdened by chronic disease, and those that we love are burdened by caregiver burdens and loss of productivity, et cetera. But, if you get sick, there needs to be effective medicines too. We need both. We need an all of the above strategy to address it. And our industry wakes up every day trying to address chronic disease. Cancer mortality is down by 30%. We have, AIDS is being managed as a chronic disease, curative therapies for hepatitis C, the GLP-1s for obesity. Obviously, better medicines, better treatments and cures can be a huge contributor to better health. But we need both. They're right to focus on prevention and root cause. And then just in closing, I would say that we need more attention. Policymakers need to continue to focus on sort of the middlemen in our system, because we have a situation today where over 50% of what's spent on brand medicine goes to people who don't make the medicine. We have a situation where PBMs, pharmacy benefit managers, control 80% of the market today, and they negotiate considerable rebates and discounts from our members. My son has type 1 diabetes. Insulin's in the news a lot. The reality is it's really should be criminal for patients to have to show up at the pharmacy and pay the full list price of insulin when the PBM is getting a 50 to 80% discount on the drug. PBMs are paid based on a percentage of the list price of the drug, and as a result, the FTC and other people who've looked at it have shown that they actually prefer higher priced medicines because they get a higher rebate on those medicines. They own their own pharmacies. They're vertically integrated. They can pay their own pharmacies 90% more than they pay community pharmacies. So we have to get at that. Senator Cassidy in the Senate just launched a report yesterday on another middleman, which is hospitals, in the context of the 340B program. Hospitals can buy a drug for as little as a penny, mark it up by 1,000% to a commercial payer or to the Medicare program, and there's no guarantee that arbitrage is actually making its way to patients in the form of lower drug costs. So we have this system that's grown up over time where there's a lot of folks in the middle who have nothing to do with inventing the medicine, taking the risk, who are taking ever greater share and not passing it on to patients in the form of lower costs. So we've got to get at that.
Great. Well, listen, thank you so much for the conversation. Please join me in thanking Stephen.
Thank you.